Okay, up next we have our next speaker, Dr. Lisa Fitzpatrick, the founder and CEO of Grapevine Health. Thank you so much for joining us, Dr. Fitzpatrick. She is an infectious disease physician and CDC-trained medical epidemiologist. She's the founder and CEO of Grapevine Health, a mission-driven organization that focuses on promoting health literacy, patient engagement, health innovation for underserved communities, specifically digital health solutions. Please welcome Dr. Fitzpatrick as she discusses the topic, Challenges and Triumphs, a Journey Through Healthcare. Thank you so much for joining us again. Feel free to share your video and your screen and present whenever you're ready.
Okay, thank you. It's nice to be here with you, and thanks for inviting me.
Of course. Are you able to share your video?
Yes. You should see it now.
I see your screen, not your video yet. At the bottom left corner, you should see a start video icon.
Well, on my screen, it says you are screen sharing. Stop share.
I stopped screen sharing. I see your screen now.
Okay, so you can see my slides.
Yes, I can, but not your video.
Well, because it says you have stopped my video.
Oh, I have to start your video?
You were controlling it. So. Okay.
All right, thank you so much.
Okay, sure. Hi, everybody. I'm happy to share my journey with you. It's been a long journey. I graduated from medical school in 1992, so that was many years ago. Some of you probably were not born. But it's been a really interesting journey. So I'll talk to you about my career. I'll spend a lot of time talking about how I got to the position I'm in now, which is the founder of my own company. And then talk a little bit about the challenges or the frustrations that led me to start my own company. But I'll spend the bulk of my time on these first two bullets, talking about my journey and also introducing you to the CDC and the Epidemic Intelligence Service Program. So here's my journey. It'll take me a bit to get through this because I think it's important. When I went to medical school, I thought I would be, I don't know, a family practice doctor or emergency room doctor because I didn't realize how many opportunities there were out there for physicians. So I graduated from the University of Missouri, Kansas City School of Medicine. It was a 6-year combined BA MD program and did my internal medicine residency. And after that, moved to Colorado for an infectious diseases fellowship. So I'm board certified in infectious diseases. While at my infectious diseases fellowship training program, I had an opportunity to go to Zimbabwe. Sorry, I almost forgot the name of the country. I went to Zimbabwe to conduct a research study. And my program director at the time knew someone who was connected to the program in Zimbabwe, but that was all. I was given a connection. I packed my bags and I went to Zimbabwe and had to start this research program from scratch, including establishing all the relationships. And to make a long story short, that was very successful for many reasons on a personal level and a professional level. But while I was in Zimbabwe, I met lots of people from the global health community. And after learning about what they were doing, some were doing research, some were implementing public health programs, some were being physicians or healthcare providers in the rural areas of Zimbabwe. I realized my scope was way too small. So I became intrigued about public health. And when I got back to Colorado, I knew there were doctors on our staff who'd worked for the CDC. And I talked to them and they told me about the EIS program, which I will spend time talking about after this slide. CDC has a 2-year program and you have to apply for it. So I applied for the EIS program and I entered. I was accepted into the program, and I did that program for 2 years. And 75 to 80% of people who go through the EIS program end up staying at the CDC, as did I. I was there for about 10 years total. I won't go through all the different jobs I had at CDC, but I'm happy to talk to you about that if there's interest. I left CDC for a couple years though, because CDC offers what's called long-term training. And I applied for a program to get long-term training, which in this case meant getting a master in public health. Most people from CDC got their MPH in Atlanta at Emory University because you didn't have to move. But I wanted to spread my wings a little bit, and I gained acceptance to Berkeley, the School of Public Health in Berkeley. So I moved to California for 2 years, but I'm still working for CDC at this time as part of the long-term training opportunity. And it was coupled with a preventive medicine residency, which required me to work in the health department for 1 year. So after finishing my master in public health at Berkeley, I found a position in the San Francisco AIDS office in San Francisco, and I worked in that program for a year, doing a variety of things. I wanted to stay in California, but there was an offer back at CDC in Atlanta that I couldn't pass up. And it was an opportunity to build a new program that was focused on funding minority junior investigators. And the reason this is important, it's even still relevant. It's relevant now, but it was relevant then because most of the grantees at CDC were academic universities with an established portfolio of research. When junior investigators are competing in that field, it's very difficult for them to win awards because they don't have the experience. So this program was specifically designed to only allow junior investigators to compete for research funding. And the reason I love the opportunity is because it was an opportunity to build a new program, and it already had $3 to $5 million in funding promised for the program. After that, I moved to, and now we're in 2005 to 2007. I'm still at CDC, but this is my last job at CDC, and I moved to the Caribbean region because I was assigned as the CDC diplomat for the US government in the Caribbean region, where I ran the Global AIDS program. And what's interesting about this position is when you are a global health diplomat for the US government, there is a policy called One USG, or One US Government, which requires all US government agencies to work under the same umbrella. So I had an opportunity to learn a bit about how the State Department works, and I reported to the US Embassy. I was based in Trinidad and Tobago initially, and then we moved our office to co-locate with the United States Agency for International Development, USAID, and they were based in Barbados. So I did that job for 2 years, and for reasons we don't have to discuss, I decided to leave CDC after a 10-year career because I wanted to work in the community. The reason I wanted to leave CDC was related to my frustration about not being able to impact what was happening in community, but also because I was being promoted at CDC, and my concern was the more I was promoted, the more disconnected I would become from community. So if you see the pair of sunglasses next to my last CDC stint, that is because I took a year off. I didn't plan to take a year off. I only planned to take a couple months off before getting another job, but was enjoying myself so much and didn't realize how tired I was from working nonstop, from starting medical school all the way to working a 10-year career for CDC. And it worked out, so I went with it. And the next thing I know, I looked up and almost a year had passed. My next job, though, was a combination job. It was a combination of academics, research, consultation for the DC Department of Health and the National Institutes of Health. But I was based at university. And in that capacity, I helped run the Outpatient Infectious Disease Center. I brought in research grants, and I served as the principal investigator on multiple grants for the university. Sometime during my position at Howard University, I also became the principal investigator for the AIDS Education Training Center. And this position required me to train clinicians, nurses, and physicians mostly, about how to treat HIV. And that led me to a hospital, and I see now it's difficult for you to see the icon, but that is for a hospital here in Washington, DC. It's our only safety net hospital. And I learned about this hospital through my work with the AIDS Education Training Center. Once I got to the hospital and realized how much they were lacking resources, not just for specialists, but for diagnostic capability for infectious diseases, I worked with them, and we started their first outpatient infectious disease center, which I became the chief medical officer for. And I did that job for 2 or 3 years. And then it was time to take another break. These jobs I've had are all consuming, and sometimes feels like you're doing multiple jobs, 2 or 3 jobs at once. So in 2014, I decided to resign, and I was looking for a fellowship, and I learned about the mid-career program at the Harvard Kennedy School. So in 2014, I was accepted to the mid-career program in Cambridge, Massachusetts, and went to the Kennedy School for a year, where I focused on social entrepreneurship and innovation, because I have many ideas from my career across the health sector about how we should improve the health, particularly of low-income populations. And while at the Kennedy School, I met many people working in the venture capital sector, people in the startup community, people in the social impact space. And I learned a lot, and I thought about launching a company. But after these conversations, so many people recommended I look to Medicaid as the potential funder for my ideas. So after I graduated, I came back to DC, went to the Medicaid office to talk to them about some of my ideas. They weren't interested in funding my ideas, but they offered me a job as the chief medical officer for DC Medicaid. So that is how I became the chief medical officer for the city. And what's interesting about this, if you look back at my timeline, starting in medical school, there's no way I could have anticipated having this many interesting stops on my journey, or even becoming the chief medical officer for a Medicaid program, especially because I had an infectious disease training, and most of my work has been in infectious diseases. But what happened is when I went to the Kennedy School, it allowed me to pivot my career, and also the way people viewed me as someone in the health sector. So I mentioned I wanted to talk to you about the Epidemic Intelligence Service. And the reason is because a lot of people don't know about this program. And this program is fantastic if you're interested in learning about public health and epidemiology. The EIS program is, there's a fun moniker for the EIS program. We call it the medical CIA. So even now, amidst the pandemic, EIS officers are deployed around the world, I'm sure, working on coronavirus and this pandemic. But the kinds of work EIS officers do is very varied. So this is a 2-year program, and it's not sitting behind a desk mostly. For most people, it's not. There are a few positions in the statistics area in which people mostly sit in the office. But other than that, this is applied epidemiology, which is field research, outbreak investigation, program evaluation, and so many more things. And here's an example of the kinds of problems EIS officers attack. So these are mostly outbreaks. Many of these are famous outbreaks. You may or may not have heard of some of these, but the dirty little secret most people don't know is that CDC cannot learn about an outbreak and then decide to go into a state. The state has to recognize they have a problem and then invite the CDC to come in. And so generally when a state or the health officials recognize they have a problem, they will, if it's outside their capacity, they will alert CDC and make an official request for support for the outbreak. And usually that's how EIS officers get deployed into the field. So now I'm going to switch and talk a little bit about what led me to what I'm doing now. And by the way, all the photographs you see are mine. Photography is one of my hobbies. I think that's one thing that's very important, that you maintain hobbies throughout your training, because it's a lot of work, as you probably have already figured out. So we definitely need something to balance so that we can maintain mental wellness. So one of my frustrations across all these jobs is that I had an opportunity to look at data, potentially influence policy. But what I was finding was that despite all the great work we were doing, it seemed we weren't really making an impact. And I think this is one of the reasons why. So I don't know if you're familiar with logic models, but logic models are an important component of any program evaluation. The challenge with logic models, you can make them look pretty, and everyone's expecting to see a logic model, but most of the time we focus on the first three components or the first four components, but the last two are where we really need to make an influence. So the outcome. So it's fine to decide what objectives are, how you're going to gather information, and talk about what data or what the products or deliverables will be when you're finished. But then what happens? And the reason this is frustrating to me is because usually program evaluations or even investigations, a lot of them end up with a pretty document, an output that's sitting on the shelf until 2 or 3 years later when someone says, oh, we really should look at that problem. And then this cycle repeats, but we never really focus on the last two columns, the outcomes. What actually happened? What did we change? And how many people did we help? So because of this, I conducted some personal reflection and realized that these are some of the things I'm most passionate about. So in the health sector, what if we could engage community in the way they want to be engaged? Some of you may know, if you're already working in the healthcare system as a clinician, you know we have a problem. At least pre-pandemic, we had a problem with emergency room overuse, and also people with repeat admissions to the hospital. That's because we haven't done a good job engaging people in healthcare. And partly that's because we don't tailor services. Healthcare in the United States is basically one size fits all. And I started to think about, this is around the time Amazon began to emerge, and I wonder, well, why can't we tailor healthcare services the way Amazon will tailor your shopping bag? But in order to do that, we need a huge shift in culture. And because these are the things I was thinking about, and I think they're so divorced, maybe less so now, but they're so divorced from the status quo in medicine and healthcare, I decided to leave and start my own company, which brings me to Grapevine Health. Grapevine Health is, actually, let me show you this slide. Before starting Grapevine Health, I I did a bit more soul searching, and I thought, well, what's really important to me in healthcare? And I have so much respect for Sir William Osler because almost every time I hear or learn one of his quotes, it really resonates deeply with me. And one of my frustrations in healthcare, and maybe you've noticed this as well by now, we are very good at writing prescriptions and giving people medication, less so on education, helping people understand or addressing low health literacy or focusing on prevention. So I decided I would love to figure out how we can keep people healthy or make people healthier without medication. So these are the things I wanted to focus on: mental health and substance abuse, and health literacy, food and nutrition. So I'll come back to this in a few minutes. So I'm fast forwarding. I resigned from my position at the DC Medicaid program about a year and a half ago. And the idea was to see if I could start a company that was focused on a lot of the things I just talked to you about. So Grapevine Health is a new company, and it is not a nonprofit. It is a for-profit company. And the business model, we hope, right now we're very much in the listening and designing phase to see if we can increase credibility, trust, and following in the community. But ultimately hope that we can develop a series of interventions that we can sell to insurance companies to help keep particularly Medicaid beneficiaries healthy. So what are we doing at Grapevine Health? Grapevine Health initially was founded after I started a series called Dr. Lisa on the Street. And I probably should have put a Dr. Lisa on the Street video in here to show you, and I didn't think of it. But I'm inviting you to go to YouTube. You can go to the Grapevine Health channel on YouTube and just look at one of the videos. But essentially, it's man on the street. I'm talking to random people about a health issue. And the reason I started that is because I wanted to understand what it would take. Is there a way to educate and entertain at the same time? So after Dr. Lisa on the Street, I continue to think about what are the other components that might engage people in learning about health or being interested in health. I also learned through a lot of my interactions that people are just frustrated because they don't understand what doctors are saying, which is a great lesson for you to know now, because it's really important to become conversant in community speak and what they call doctor speak. And it's unfortunate that so many physicians forget they should be speaking in community speak, but they're speaking in doctor speak. So we've been making video content, mostly now when we're conducting outreach in the community, we might make a few videos, but I've also started having conversations with experts during the pandemic, mostly to address a lot of the misinformation that's out there. So you see in one of the videos, I'm wearing a mask and I'm talking about all the misinformation about wearing a mask, because so many people think, oh, you shouldn't wear a mask. You may have heard this because it causes CO2 poisoning. But I think a lot of people don't really know what that means. But I think the sky's the limit for topics we could cover on Grapevine Health and through Dr. Lisa on the Street. We conduct outreach, which is reflected in these pictures below. And we started a podcast a couple months ago. And the purpose of the podcast is to highlight community voice. So what's different about us is we're not talking to experts. There are thousands of podcasts out talking to people who are already visible, people who are leaders in healthcare systems and other sectors. But we really want to talk to the community member and gain insights about what we need to be doing to improve health engagement and outcomes for particularly underserved communities. So a lot of our community education pre-pandemic, and to some extent we still do some of this, but it's mostly on the street, impromptu. But town hall meetings, we go into housing communities. This picture is one of my favorite pictures of all time. mostly because of the young men who are in the picture. These guys are historically, as a demographic group, thought to be those who are unengageable. They're not interested. They are so hard to reach. And just a word about saying people are hard to reach. I don't like this term. No one is hard to reach. We just have to do the work to figure out how to reach them. There is always someone who can get through to someone, and we are not good about doing the work to figure out how to get that done. So in this case, just showing up in their community created an opportunity for us to have conversations with them. So what are we doing now at Grapevine Health in addition to the things I've already told you? We're focusing on building relationships with community partners. And so I reached out to Headspace because I'm very interested in addressing the trauma in low-income communities, particularly. And we just wrapped up early data collection for a mini study looking at the acceptability and feasibility of using the Headspace app with Medicaid patients. So we'll be looking at the data with our Headspace colleagues. And for those of you who may not know, I'm assuming everyone knows, but Headspace is a meditation app. And we already talked about Dr. Lisa on the Street and community engagement, but health literacy is the foundation of Grapevine Health. I think low health literacy leads to poor health outcomes. It also deepens distrust because of the confusion related to misinformation. And one of the shelters I volunteer at, I had a listening session with the gentleman, and one of them said to me, "I don't understand what you doctors are saying. And if I don't understand you, I don't trust you." And that's just another example of why it's so important for healthcare providers to speak in a language that resonates with people. And then finally, I have a personal passion around food and nutrition and understanding how we can change what I call the community palette. I live in an underserved area in Washington, D.C., and when I drive around my neighborhood, most of what I see are carryouts and fast food. So if that's all that's around you and you don't cook at home, you become accustomed to the taste of fast food. Not only does it taste good, it's filling. So it's not enough to introduce fresh fruits and vegetables or to have farmers markets without also educating and exposing people to different kinds of food. So we are partnering with another organization, the Alliance for Food, to conduct an RCT, a randomized clinical trial, looking at the biological outcomes associated with food. And so these groups will be randomized to a control group and then a group of families, and we provide all their food and we do the biometrics on all the families and assess over time what's happening with them physiologically. So I'm really excited about that study. So I've been talking for 30 minutes, which is a long time for me. I'm not used to giving such long talks anymore. But before I end, I could give you so much advice and you can ask me specific questions, but this is my only piece of advice for you right now. As you could see from my career, I thought I was going to be a primary care doctor sitting in an office, seeing patients. And my career has taken me everywhere but. So keep your options open, keep your mind open, and don't feel like you have to follow the traditional path if it's not for you. So with that, I'm going to turn this back over to Alexia.
Thank you so much, Dr. Fitzpatrick, for your presentation. It was very, very inspiring. I know for me, and I can speak on behalf of all the audience members here as well. We are going to transition into our Q&A session with you, Dr. Fitzpatrick.
Okay.
We have questions right now in the Q&A, and I'm sure multiple more as students hear your responses and think of questions on their own. Pre-health individuals in the audience, please make sure to use the Q&A feature for any questions, and I will make sure your question gets asked. So the first question is, What made you decide to specialize in infectious diseases?
That's a good question. It was an iterative thing. I didn't actually like infectious diseases when I was a medical student because I hated microbiology and I could not learn all those antibiotics. It was so uninteresting to me. But I think the challenge for me in medical school was that I wasn't connecting the dots. I was just thinking about each class on its own. And I think medical school curricula have changed now so that you all have more of a systems approach and you are connecting the dots. But back then, I wasn't making the connection between, let's say, pathology and so pathology in the lab, and then I'm seeing a patient. The patient is exhibiting what I was studying on the cadaver, but I wasn't making those connections. And so it's the same thing, I think, when I try to figure out what to do with, with my career. So when I graduated from medical school, I thought I was going to be an ER doctor. So, but I wasn't sure. So I found an internal medicine or rotating internship. I don't know if they still have those, but a rotating internship gives you lots of electives. And the program I found was in Michigan, and it gave me 7 electives. And I went to that program because it gave me the most freedom and flexibility to explore lots of different things. So I took 3 months of emergency room and I hated it. I hated it because I felt like emergency rooms are like clinics. I went there for, the sirens and the excitement, and that's probably 10 or 15% of what you see in an emergency room. So I decided, well, this isn't really for me. So I continued on my rotations, and what I fell in love with was ICU critical care. And it made sense because the same things I loved about the excitement of the ER, I could get in the ICU. The dynamics of the physiology and the pharmacology right there, you could intervene. It was fast paced. And I was on call one night during my residency. It's about 3 a.m. And a morbidly obese patient extubated herself. She dislodged her tube, and I couldn't get it back in. And I called my attending at 3 o'clock in the morning, and he had to come in and help me. And number one, I felt horrible. But number two, that was the night I changed my mind about becoming a pulmonary critical care doc, because I always tell this joke: what is the difference between an A student and a B student? And for me, the answer is sleep. I had a roommate in college. She was always pulling all-nighters, but I've never been built to be able to stay up all night. And if I don't get at least 5 or 6 hours of sleep, I don't function well. So it's amazing I finished residency, but I did. But after that experience, I realized, do I want a lifetime of waking up in the middle of the night for critical care emergencies? So I continued my internal medicine residency and started to take subspecialty rotations. And again, was drawn to infectious diseases, largely because of the attending I had was an excellent teacher, and started to help me realize, okay, there's a lot, the things I like, what I'm looking for variety. I'm looking for immediate gratification of patients improving. And I love the idea that you can see a surgical patient, or you can see, someone with HIV or someone who has tuberculosis or meningitis. And there was just so much diversity. Not to mention, when I was an internal medicine resident, I went to Africa twice. I went to Swaziland for 6 weeks, and then I went to Kenya, and realized there's the world of infectious diseases is like endless and fascinating. And that's when I decided I wanted to pursue infectious diseases, because it's so linked also to global health, which is something that's very interesting to me.
Absolutely. Absolutely. Thank you so much for your response. Next question. Do you recommend any internships or volunteer opportunities to get involved in your efforts? Otherwise, your efforts is like your involvement with Grapevine Health and how you support your community.
I don't understand the question. Can you ask me a different way?
Yeah, of course. Do you know of any resources that students can find? We have a lot of students all over the country here who might also be interested in promoting health literacy in their communities or volunteering in that effort. Do you know of any resources that could extend to that?
Unfortunately, I think this is local. I mean, one of the reasons I started Grapevine Health is because I ultimately wanted to have a national presence. And I've been talking to different doctors in different cities who are also interested in health literacy. And ultimately, I would love to tie us all together into one entity. But we're in such early days, we're not there yet. I think it's hard to find specific organizations that are just focused on health literacy, but there are tons of organizations in every city that are focused on social services related to health, health communications. There are so many things going on, nonprofits, community-based organizations, and so I would just do some research in your city to find out who's doing what. Also, figure out the population you want to work with because that helps narrow it down so that you're not overwhelmed and looking for um, volunteer or service opportunities. I also, and I'm speaking from experience, I have a problem with analysis paralysis. So if there are too many options, then I sometimes just don't do anything. So I would recommend just picking one, trying it out. If you don't like it, move on to the next thing because there are just endless opportunities to jump in and get involved. And I think that's so important, particularly when it comes time to look for residency programs, because now more than ever, residency programs are looking for people who are well-rounded and not just good scholarly students.
Thank you so much for your response. Next question, can you describe what it is like working for the CDC and what a typical workday looks like for you?
They're never the same. That's the great thing about working for CDC, especially when you're an EIS officer. So when I joined the EIS program in 1998,
Yeah.
uh, the first outbreak response I had was tuberculosis in a daycare worker. So I had to fly to Gulfport, Mississippi, and I just had to jump in and put all those principles we learned in this 3-week crash course, put them into play to try and figure out how we would handle this investigation. That involved interviewing people, collecting survey data, talking to the lab. So it depends on what's going on, but most EIS officers are usually deployed somewhere doing something. I also had two investigations in North Carolina, and you go to these places and you stay there until you finish the investigation and get the data you need and make some recommendations. I had, where else did I have an investigation? Michigan City, Indiana, one of the most fascinating outbreaks. And actually I published a paper on this, so you can look it up on the internet because it was so long ago. You can get free access to the paper, but it's entitled, if you put my name, Lisa Fitzpatrick, and then put a tuberculosis outbreak investigated through a social network, it should come up. And the reason it was so fascinating is because the health department called CDC when they found this cluster of TB cases, and they couldn't figure out how all these people were linked together. So they called us in to help them. Well, I got on the ground and it just so happens I'm Black. All the TB cases that couldn't link to the outbreak were also Black. And we found how these folks were linked. So it's a really fascinating investigation. It was really fun. And then finally, I also led an investigation of HIV transmission in 31 Georgia prisons. So there are just so many different activities. I mean, I can't even do it justice. It's definitely not the same thing every day. Some days you're in the office, you have to write up reports. There are always meetings. But if you're an EIS officer, you're probably traveling at least 50, 60% of the time. in the field.
That's awesome. Do you enjoy having an ever-changing work life each week?
Well, I did then, but even to an extent now, I mean, as you can tell by my career, I've had several pivots in my career. And part of that is because I get frustrated, as I described, but also because I like the variety. So I do enjoy that. Yeah. So, and some people, they're different. I have a friend who I went to medical school with, and he is just now retiring from the same practice. He was in the same practice since he finished his residency. So we're all different creatures, and there's just no right or wrong answer for how you move after you graduate from medical school.
Absolutely. Would you say medicine is a continuously changing career?
No, for a lot of people, it actually isn't. I would say I'm kind of an outlier. I mean, I think my story, that's why I spend so much time on my timeline. I think my story is pretty unique. Even among EIS officers, I have lots of EIS officer friends. Once they finish their fellowships or residency, they stayed at CDC because most EIS officers enter the public health service. And if you stay in the public health service for 20 years, you get a pension. And that's why they're still there. But I left after 10 years because I wanted to do something different. So again, there are no rules.
Absolutely. Thank you so much for your responses. Next question from Alice in the audience. Thank you, she says, for sharing with us your impactful journey. How would you respond to people who doubt your impact or devalue it?
I don't. So this happens. So are they not able to communicate with us, the people who are asking these questions? Because I want to give that person an opportunity to give follow-up information for the question. So there are so many different ways I can answer that question, but I'd like some more context. So if whoever wrote that question could add on to the question, and then we can take the next question in the meantime.
Alice,
But it's a great question.
Alice, if you're available, could you please raise your hand and add on to your question if possible? You just click on the raise hand, perfect, and I will allow you to talk. Hi, Alice, go ahead.
Hi, thank you again, Dr. Fitzpatrick. I really admire people who does what you do in terms of outreaching to those who are underserved, as you said. But I guess what I'm trying to, get from the question is, because I ideally would like to do something of that sort where I can at least get some volunteers or some people to come together and kind of serve a purpose in a community. So, and then I also wonder how you continue to push yourself when I guess there are people who tells you to focus your energy elsewhere and stuff like that. Does that give you more?
Well, are you a medical student?
No, I want to be an occupational therapist. So it's not.
Oh, but you're a student right now.
I'm a pre-OT student, so I'm applying for programs now.
Okay, so and thank you, because that's why I needed the context, because my situation and your situation are very different. They're apples and oranges. So at your stage, I actually think that's good advice. I think you have to finish your degree, get established, and then figure out how to wander and explore things. You need to get the foundation first. And once you have that, but at the same time, if you want to accrue the experience with volunteering and outreach, that's all possible while you're getting your degree. But I would say your highest and number one priority is finishing your degree so that you position yourself for success down the road. The only reason I had the confidence to do all these things I've done is because I'm now a medical doctor. And I finished my residency. So not only did I finish medical school, I was a board certified doctor. And then I started exploring because I had the foundation. So once you have that foundation, then I think you carry on doing whatever feels right to you. That's what I meant by following your arrow. But I just want to encourage you. I mean, don't lose that sense of adventure and spirit. And you can do that. Out in the world, we call these passion projects a side hustle. So you can have a little bit of a side hustle while you're a student, but just get the work done first.
Okay, thank you.
Mm-hmm.
Thank you, Alice. Go ahead and stay on here. I'm going to ask your second question just in case you'd like to add on to it. Alice also asks, how do you continue to push yourself in your strong community outreach?
Oh, well, that's a natural desire. So again, all these things I've done have led me to this moment. And all of those positions I had, those are all leadership positions. So again, because I had the foundation, I seized opportunities, I tried different things, and I just kept learning about where my passion was and what I ultimately wanted to do. And that's why it took me so long to take the leap and start a company. But listen, I'm 52 years old. So I've been at this for a while. I graduated from medical school in 1992. So, back in the 90s and the early 2000s, I was, getting experience. I was being a leader within agencies and organizations, all the while realizing, while this is gratifying, there's something missing for me. I want to be connected to the community. And so that was my goal. So all of those jobs I had, I still maintained some connection to community, but it wasn't what I was primarily doing. The best example of that is when I was at CDC, I did a lot of town hall meetings in Atlanta. So it was scratching my itch, so to speak, but I still had a credible position at an organization. I mean, to be able to say, when you walk into an organization or a group of people and say, I'm Dr. Fitzpatrick from the CDC, like that's a big deal. And so having that foundation and that track record set me up to be able to take the leap to do what I'm doing now. So related to your first question about worrying about what people think about the decisions I've made, at this point, they don't matter to me at all. And if my business doesn't work out, I mean, I already have 3 job offers right now, but I'm not interested in them because I want to see if I can grow my company.
Thank you so much for your response.
Mm-hmm.
That was awesome. I think we have time for one more question. And so I want to ask the question, what are some of your favorite projects to promote health literacy with Grapevine Health?
Well, that's easy. That's hands down Dr. Lisa on the Street. And the reason I love Dr. Lisa on the Street, and I actually over the years, have not spent a lot of time on Dr. Lisa on the Street because I've been getting distracted. And now I'm more focused, and that's where I'm going to be spending my time. But I love it because the beauty of it is it shows how universal confusion is about health information. And this is an opportunity to get in front of people and help people understand. I mean, people say, oh, well, that's so amazing. You don't make people feel stupid. That's what people need. They need the lack of judgment, the lack of bias. They need understanding because all they want is peace of mind to make sure, that they can be healthy. So I've started telling people I'm in the peace of mind business because I'm demystifying and helping people make sense of health information. Although the coronavirus pandemic has been quite challenging, but I'll keep pushing.
Thank you so much, Dr. Fitzpatrick, for sharing your story and your impact on population health and your amazing company and efforts for promoting health literacy in our communities in DC, and hopefully after influencing the attendees in this audience, also on a national level around the country and the world. So thank you so much for joining us today. We hope you have a wonderful rest of your day and weekend.
Okay, thanks for inviting me. You all take care and good luck.
Bye, have a good one. Thank you so much.
Bye.
Okay, before we transition into our next guest speaker, we are going to take a short 10-minute break Our next guest speaker is Dr. Jennifer Weiss from the Los Angeles Medical Center, and this will be at 6 p.m. Eastern Time. So don't go anywhere. Feel free to get a drink of water or anything, but we will be back very shortly in 10 minutes.